Hello, my name is Nadira Asila binti Muhammad Zamri, number matric 069085. So today I will present about lumbar spondylosis. The definition of lumbar spondylosis is a chronic non-inflammatory disease caused by degeneration of lumbar discs and facet joints. The etiology of lumbar spondylosis is multifactorial. Spondylosis is age-related change of the bones, vertebrae and discs of the spine. These changes are often called degenerative disc disease and osteoarthritis. When this condition is in the lower back, it's called lumbar spondylosis. These changes don't always cause symptoms, but they are a common cause of spine problems that can range from mild to severe. Next, the causes of lumbar spondylosis is repetitive stress, wear and tear as well as injury. Then, dehydrated discs due to aging, herniated discs due to aging, bone spurs due to disc degeneration, and stiff ligaments due to aging.
In most cases, lumbar spondylosis occurs as a result of degenerative changes in the spine as we age. Intervertebral discs become dry and thin around the time you turn 40. Disc degeneration can cause herniation, one of the signs of lumbar spondylosis. Aging can also produce signs of spondylosis, like bone spurs on the vertebral body or facet joints in the lumbar region of the spine. With age, ligaments that bind the spine together become thickened and stiff. This condition also can cause symptoms of lumbar spondylosis. Usually, lumbar spondylosis occurs in the elderly, but some factors contribute to its development in young people. One major cause is an injury to the lumbar region of the spine. Overweight and inactivity are also risk factors in the development of lumbar spondylosis. Holding your lumbar spine in an uncomfortable position for prolonged periods can contribute to the development of spondylosis.
Next is pathology of lumbar spondylosis. Pathology of lumbar spondylosis have three phases, that is dysfunction phases, instability phases, and stabilization phases. Dysfunction phase outlines the early consequences of repeated microtrauma, with the emergence of circumferential painful tears of the outer, innervated annulus, and concomitant end-plate separation that may impair the nutritional supply and waste clearance of the discs. These ribs may combine to form radial tears, which are more likely to protrude, and which affect the disc's ability to retain water, leading to desiccation and a decreased disc height. Instability phase is characterized by the loss of mechanical integrity, progressive disc alterations, including internal disruption, more annular ribs and disc resorption, along with further facet degeneration that may lead to instability and subluxation. Stabilization phase sees continuing fibrosis and shrinking of the disc space, as well as the development of osteophytes and transdiscal bridging. Clinical features of lumbar spondylosis is low back pain, leg pain, difficulty of walking, intermittent acute attack of pain with total relief, usually produce no symptom, tenderness in nerve compression. Objective assessment. First, general examination of the spine. Inspection of the entire spine. Look for any obvious swellings or surgical scars. Assess for deformity, such as scoliosis, kyphosis, loss of lumbar lordosis, or hyperlordosis of the lumbar spine. Look for shoulder asymmetry and pelvic tilt.
So I'm going to start off with the back. Looking from the back is ideal for looking for any scoliosis, so an abnormal curvature of the spine. It's also a good position to look at the muscle bulk, and here we're looking for symmetry. I'd like to now just ask you to turn onto the side, and as you can see, this is a good position to examine the curvature of the spine, and what we'd expect in a normal spine is a cervical lordosis, a thoracic kyphosis, and then a lumbar lordosis. And in some conditions, you'll get a flattening out of those normal curvatures.
Second, palpation. Palpate for tenderness over bone and soft tissues. Perform an abdominal examination to identify any masses and consider a rectal examination to exclude other pathologies in this region.
Feel. Next, we're going to move on to palpation. So I'm going to feel initially down the spinous processes for any tenderness. Let me know if anything's uncomfortable at all. That all appears to be okay. And I'm just going to feel over the sacroiliac joints. Again, let me know if anything's uncomfortable. And then down the paraspinal muscles.
Third is movement. For example, flexion, extension, lateral flexion, and rotation. Examination of the spine must also include examination of the shoulders and examination of the hips to exclude these joints as a cause of the symptoms.
So next, we're going to look at movement of the lumbar spine. So we're going to look at flexion first. So if I could ask you just to face the back. And then if you stand with your feet shoulder width apart, you're going to keep your knees straight. I'm just going to place my fingers over the lumbar spine. I'm going to ask you just to bend over and touch the floor if you can, keeping your legs straight. Go as far as you can, that's great, and back up. And then as your lumbar spine moved, what happened was my fingers moved further apart. So now we're going to move on to test extension of the spine. And this time I'd like you just to bend backwards as far as you can. That's great. Thank you very much. And back up. Okay. And now we're going to test lateral flexion. So if I could ask you just to turn around. What you're going to do with this movement is just slide your hand as far down your side as you can. So if you could just go one way, as far as you can, that's great. And then the other way.
Next is neurovascular examination. For example, sensation, tone, power, and reflex should be assessed. All peripheral pulses should also be checked, as vascular claudication in the upper and lower limbs can mimic symptoms of radiculopathy or canal stenosis. Diagnosis for lumbar spondylosis is X-ray, CT scan, and MRI. Doctor management for lumbar spondylosis have two types, that is non-surgical management and surgical management. For non-surgical management, we use non-steroidal anti-inflammatory drugs and NSAIDs such as aspirin, ibuprofen, naproxen. Next, therapeutic corticosteroid injection, and then lumbar facet joint injection. Doctor management for lumbar spondylosis for surgical management is spinal fusion. This is the most common surgery for chronic non-specific back pain with degenerative changes. Joining of vertebrae together aimed at limiting the motion between vertebrae stretched on associated nerve. Next is laminectomy. This is the most common surgery for lumbar spinal stenosis, removal of part of the bone spurs or ligaments aimed at relieving pressure on spinal nerve can make your spine less stable. Next is foraminotomy. This surgery is used to relieve pain associated with a compressed nerve in the spine. Physiotherapy management for lumbar spondylosis is first, soft tissue mobilization, that is massage. Massage will not reverse the forward seepage of the vertebrae, but it can greatly help in pain management and restoration of biomechanical balance in the area. Next, stretching exercise and strengthening exercise can help in managing lumbar spondylosis. Next, restoring range of movement may lead to small improvement in both pain and function. Next is postural improvement, home exercise and self-management techniques, shock wave therapy, and TENS treatment. This is stretching exercise for lumbar spondylosis. This is postural improvement exercise for lumbar spondylosis.